Yeah, in front of the thyroid, and just can see the difference between the echogenicity between the strap, which is usually darker than a normal thyroid gland, um, and posterolaterally, you can see the carotid arteries on each side, and they are, as you can see, they are dark as well because they just have fluid. Occasionally, you can see the esophagus on the left-hand side of the trachea behind the left thyroid lobe. And when you apply the Doppler mode, you can see the vascularity. You can see it's nicely there's no increase in the vascularity. Just corresponds to the thyroid vessels, and you can see the brightness into the carotid artery. And lateral to this is the internal jugular vein. Next, please. Right, so
I'm sorry.
that's right. Yeah. So no, back.
One before? Yes.
Yeah, that's one. Yeah. Okay. So this is what we call it U2. These are the vast majority of thyroid nodules, which are benign, and are different findings that you can see that is still considered benign. So if you see a slightly hyperechoic nodule, which is slightly brighter than the normal than the remaining parenchyma of the thyroid, then this is considered benign, unless it is very hyperechoic. Also, an isoechoic nodule has same sort of brightness as the remaining thyroid tissue that's surrounded with a halo is also considered benign, as long as this halo is thin and does not have a varying thickness. Cystic changes are very common, and cystic nodules most of them are considered benign, and if they have colloid deposits inside them, which I'll show you to now, this is also a very reassuring sign. Spongiforms are very commonly seen, and you will read this on ultrasound scans. This is a nodule which has a lot of small microcysts, more than 50% of the nodule. And again, this is a reassuring sign. If there is eggshell calcification, if this surrounds the whole nodule, then this is also considered benign feature. Sometimes if it is not encircling the whole nodule, but you cannot see any extension of the nodule into the surrounding tissue, or if the nodule is not hypoechoic, not very dark, then this is also considered benign feature. When you apply the Doppler on a nodule, and you can see that the vascularity is mainly in the periphery, and so this is also a benign feature. And this is the so next, please. Right, so this is an example of a spongiform nodule. It's more obvious on the right-hand side than the one on the right side. You can see multiple small cystic spaces, and you can see the spaces are dark. They are hypoechoic, and this fills the whole nodule. And if you remember from histology, there are the thyroid is small colloids colloid nodules next to each other. So these cystic spaces just filled with colloid material. Next, please. Right. Another benign feature is someone says cannot hear me. Can you guys hear me okay?
I can hear you from my side here.
Okay, good. Right. Yeah. So another benign nodule is the cystic nodules. And remember from the beginning, I said fluid will look very dark, and these nodules are very, very dark. But you can see these small foci of increased echogenicity inside them, which corresponds to the colloid deposits inside these nodules. And again, this is a reassuring sign that too, this is a cystic colloid nodule that you are unlikely to need to biopsy. Next, please. Right, again, the calcification. So there are different types of calcification. The one that is considered benign is the eggshell, where there is the calcification that surrounds the whole nodule. If there's area where it's not completely surrounding, but you cannot see any extension outside the nodule, then still considered benign. So you are unlikely to need to biopsy this. Next, please. Right, vascularity, and as I said, peripheral vascularity in an isoechoic nodule that has some colloid body. So the picture on the left top, you can see in the center some colloid body deposits in the center, and the nodule has a echogenicity similar to the surrounding thyroid tissue. On the right hand side, when you use the top Doppler mode, you can see that the vascularity is just in the periphery, and there's no significant vascularity in the center of the nodule, and this is a good sign. And the lower picture on the left, there's just one lower down, and you can see also again a just peripheral vascularity, which is a benign feature. Next, please. Right, so now starting from U3, 4, 5, these are the nodules that you need to do a fine needle aspiration. So any of these features means that there is a chance of malignancy, and then you have to do a biopsy either to confirm or exclude this. There are different features that are considered indeterminate. So if there is a very hyperechoic, markedly hyperechoic nodule that is very solid and surrounding with a halo, and the nodule looks homogeneous, then this could be a follicular lesion or follicular neoplasm. And as you know, follicular neoplasm could be a follicular adenoma or follicular carcinoma. But if you see a hypoechoic, means that it is dark, and so if there's a nodule that has some sort of mixed cystic solid, and the solid part is very, very hypoechoic, then this is also considered indeterminate. Another important thing is if there is an internal vascularity or mixed vascularity, central and peripheral, then this is also raised the suspicious or possible malignancy. Next, please. Then U4 is suspicious, so the risk of malignancy is higher. So a solid hypoechoic nodule with some irregular borders as well, that is suspicious. If there's then what's called very hypoechoic, and this will be very dark, even darker than the strap muscles, which, if you remember, I said that the strap muscles are usually darker than the thyroid gland. So if you have a very hypoechoic nodule, this is very suspicious. And if there are some disrupted calcification in a very dark nodule, and you can see the hypoechogenicity is extending outside, this could be a papillary thyroid carcinoma. And also, if the outline is very irregular or lobulated, then this is raised the suspicion of malignancy. Next, please. Then U5 nodules, which are very likely malignant, and you still need to do a biopsy to confirm this. So if there's a solid nodule that is hypoechoic and has some irregular margins, and there is multiple microcalcification inside this, then this is very likely a papillary thyroid carcinoma. And if you have the same features, but the calcification are globular rather than small microcalcification, then this could be a sign of medullary carcinoma. If there is a significant increase in the vascularity in a solid nodule with very irregular margins, then this is also very likely malignant. Another important finding, if the nodule is taller than wider, so the anteroposterior length is longer than the transverse, and I think this was adapted mainly from breast ultrasound, but it does work as well for the thyroid. So this is a sign of possible malignancy. And also, if you see abnormal lymph nodes in a patient with a abnormal looking thyroid nodule, then this is very likely thyroid cancer. And if you see some calcification inside this lymph node, then this is very likely coming from a thyroid origin, if you see the same calcification in the thyroid as well. Next, please. Right, so this is some pictures of increased vascularity. So the picture on the left was a patient I operated on recently. You can see there is increased vascularity central and peripheral as well, with mixed echogenicity of the nodule. This came back as minimally invasive follicular carcinoma. Then on the right side, you can see before and after applying the Doppler, and you can see the significant increase in vascularity and a very solid nodule, which has increased risk of malignancy. So we need to do a biopsy for this. Next, please. Then the abnormal echogenicity. So on the left-hand side, you can see a markedly hyperechoic nodule, which is solid, means that it's packed with cells and surrounded with halo, which is that sort of black color that surrounds the nodule. It has varying thickness, which is also worrying, and this is characteristic for follicular neoplasm. On the right side, you can see a hypoechoic nodule in the left thyroid lobe. I don't know if you can put your cursor on that one.
Is the one above or down?
Above on the right-hand side, yes, that hypoechoic nodule in the left thyroid lobe. That's fine. It's very obvious. And then the two images below, you can also see some hypoechoic nodules as well, which is considered at least indeterminate. Next, please. Right. Again, another finding which can raise the suspicion for malignancy. If you see a nodule that has a anteroposterior diameter longer than the transverse diameter. So on the left-hand side, you can see when the radiologist was trying to do the measurement, and you can see it is definitely taller than wider. On the right-hand side, you can see that the length between the two B's is much longer than the two A's, which means that it is taller than wider. Next, please. Then the nodule margin, and you can see different margins. So the first top one on the left, where you can see small x's on the margin. This has a well-defined margin, which is reassuring. Then the one with the yellow arrows next to this has a lobulated margin, and this is a sign of possible malignancy. You can see that the cancer cells are trying to go outside. The nodule has this slight lobulated appearance. Then below this, on the right-hand side, you can see these white arrows, which show you that the nodule is trying to infiltrate the surrounding with this irregular margin. Then on the left of this, you can see a very irregular margin in a very hypoechoic nodule. Then on the left of this, you can see a halo that surrounds the nodule. And as I said, if it is thin with no significant variation in the thickness, then this is a good sign. But if it's very thick and there's a significant variation of thickness of this, then this a nodule that I would recommend biopsy. Then below, on the left corner of the screen, you can see a hypoechoic, slightly dark nodule with some possible infiltration of the strap muscles there. Next, please. Right, so calcification. So if you remember that a calcification that surrounds the nodule nice and smoothly, eggshell calcification is benign, but there are other calcification which are sign of possible malignancy. So on the left top left image, you can see multiple. Well, actually, the top 3 photos, you can see scattered small microcalcification in the solid compartment or the solid part of each nodule, which is raise the risk. There is the suspicion for papillary carcinoma. Then you see on the lower left-hand side, there is a globular calcification, which is a sign of possible medullary carcinoma. And in the right corner of the screen, you can see some disrupted calcification, and you can see that the hypoechogenicity or the darkness or the blackness is extending outside the nodule into the surrounding isoechoic tissue. Next, please. Right, so as I said, U3, 4, 5, you need to do a biopsy to confirm the diagnosis, and ultrasound scan is much better than if you do it blindly. I don't think anyone do now non-ultrasound guided biopsies from thyroid. And then this will be analyzed by cytologists. It would be great if you have cytologists on site, so that can tell you this is insufficient. You can repeat it. If not, then will be just sent to your histopathology department. Next, please. Right, so we've spoken about the different types of nodules and features that can tell you this is benign or cancerous, and this is the most important function for ultrasound scan in thyroid. But you can also see changes in different benign diseases in the thyroid, such as Graves' disease, where the glands will be very vascular, diffuse vascularity all over the gland, and it would be diffusely enlarged as well. Yeah, so it'd be diffuse, increasing the vascularity. The gland will look heterogeneous due to possible inflammation. Also, the gland will look very large, and you can see here the isthmus is much thicker than the normal gland that we did share initially. The echogenicity can vary, but most of the time it can be reduced, but it can vary in Graves' disease. Next, please. Pictures from thyroiditis. The commonest is Hashimoto's thyroiditis, where I think it just keep
Yes.
Yeah, the gland is hypoechoic dark, and there are some fibrous bands all around from the fibrosis, which will look brighter or hyperechoic. Is usually very heterogeneous due to infiltration with inflammatory cells, and initially it would be hypertrophic, enlarged, and then will atrophy with time. This is a picture of a multinodular goiter, where you can see some isoechoic or hyperechoic nodule. Most of them would be spongiform. If there's any calcification, it's peripheral. It's not uncommon to see some cystic changes in these nodules. And if you put the Doppler, you can see peripheral vascularity rather than central. So something that you can see also with ultrasound is thyroglossal cyst. Remember, fluid will look very dark, so it would be a very dark structures between the strap muscles, either superficial to it. So here's a strap muscle and here's the other side. So either superficial to it or in between them, and it can be at any level up to the base of the tongue. So another important thing that you can see in ultrasound scan is when you report on lymph nodes, and it is important to tell the location. As previously said in previous presentations, you have different levels. You need to mention which level you can see a lymph node. Ideally, you will measure in 3 dimensions. If there is a preserved fatty hilum, or is it lost? The pattern of the vascularity, is it just in the hilum, or if the whole lymph node is vascular? Also, you need to comment on the echogenicity of the lymph node. Are there any cystic component? Are there any calcification? Is it uniform or not? So a normal looking lymph node will look oval, and this is a very important sign, like a fusiform shape, and is wider than longer. Size can vary. I mean, you can see normal lymph nodes in level 2 up to 2 centimeter or 20 millimeter, which can be just reactive. But change in size is a very important thing. So a lymph node that is increasing in size, then this could be a sign of malignancy. You can see here, can see this image here on the right hand side. So this is a drawing of a lymph node. You can see this is the hilum here, and usually this will be brighter compared to the remaining parts of the lymph node, and the vascularity is usually just at the hilum in a normal gland. So a lymph node is usually hypoechoic with a slightly brighter hilum. And this is some photos of a benign or normal lymph node. On the left-hand side, you can see the lymph node is hypoechoic, dark, with a central fatty hilum, which is slightly brighter. On the right-hand side here, you can see that the vascularity is only to the blood vessels that are feeding the hilum of the lymph node. Normal lymph node will not look normally like a elliptical or fusiform or oval. They will look rounded with irregular borders. They usually have no hilum, and you can see like they all look very heterogeneous as well. With vascularity, abnormal lymph nodes, you can see significant increase in vascularity all around. Remember, the normal one will just have vascularity into the hilum, but here is extending all around. Another picture where a lymph node here, when you apply the Doppler, you can see increased vascularity, and it looks very rounded as well. Salivary glands, they usually look very homogeneous, similar to the thyroid. You should not be able to see the intraglandular duct unless there is some sort of obstruction. Also, it's not uncommon to see some lymphatic tissue inside the salivary glands, especially the parotid gland. And these are some pictures of acute hidradenitis, where increased vascularity, and the gland is hypoechoic and is increased in size as well. Here on the right corner here, you can see some liquefaction with irregularity and increased vascularity in the periphery, and this is a sign of abscess in a inflamed salivary gland. Chronic hidradenitis, the gland will be hypoechoic, but is very heterogeneous, irregular margins. You can see fibrous bands which look bright, increase in size, or sometimes atrophy, and you can see duct dilatation, as you can see here inside the gland, which is could be a sign of obstruction. Stones, if they are calcified, you can easily see them, and remember that this will reflect all the sound waves back to the machine, so what is behind this will look very, very dark. Salivary gland neoplasm, on the left-hand side, you can see a hypoechoic solid tumor inside a parotid gland. So this is a pleomorphic adenoma. On the right side, you can see cystic and solid spaces, and this is a Wharton's tumor. I will skip the Sjogren syndrome. And the last slide here is something that is relatively new, but is becoming more popular now, which is percutaneous ultrasound-guided radiofrequency ablation of thyroid nodules, which we will be starting soon in Norwich. Thank you very much.
Thank you. Thanks, Mohammed. We should have like a kind of a rest, but we're gonna continue the presentation. So next will be yeah. The next is Miss Aisha Aidan. She will gonna present the pulmonary paranasal sinuses, followed by unfortunately Mr. Afifi has have a kind of excuse, so Shadi will present on his behalf, and then lastly Professor Hazan Bashak.
Good afternoon. My name is Ayça Aydın. I'm one of the registrars in United Lincolnshire Hospitals Trust. I will present today the CT scan of paranasal sinuses and the nasal cavity of the coronal plane. We know that CT scan is essential when we're diagnosing sinus pathologies, as well as it's really important to understand the anatomy of sinuses and nasal cavity before we embark on an endoscopic sinus surgery. So I'm going to present my images starting from anterior to posterior. First of all, we know that we have 4 major sinuses: frontal, ethmoid, maxillary, and sphenoid. Here, if we start from the most anterior part, we see the frontal sinuses forming in the frontal bone, and we see here there is the sinus, the intersinus septum. We see that on the right side, frontal sinus is smaller than the other one. And then here we see the pyramid, the nasal bone, and the superior part is the bony part of our nasal septum, which is formed by the perpendicular plate of the ethmoid bone. Inferiorly, we see the cartilaginous part, which is formed by the quadrangular cartilage, which is sitting on top of the anterior nasal spine. And if we go a little bit posterior, we can see our orbits are forming here. We can see we're still able to see our frontal sinuses. Here on right side and left side, our maxillary sinuses are forming. And here we see the first ethmoid air cell, which has a specific name, agar nasal cell. Here we see again our septum, the bony part, the cartilaginous part, and our inferior turbinates. If we go a little bit more posteriorly, we can appreciate the more detailed anatomy of the boundaries of our nasal cavity. We can talk about the boundaries here. We can see the inferior part is formed by the hard palate. Our lateral walls are formed by the medial walls of the maxillary sinuses here and here. And the superiorly, we can see it is formed by the ethmoid sinuses. Lateral to the ethmoid sinuses, we have a very thin bone forming the medial wall of the orbit, which is called lamina papyracea. And the roof is formed by the ethmoid bone, the cribriform plate. Up here, this protrusion is called the crista galli, which is dividing the roof into 2, and our olfactory bulbs are sitting on top of the cribriform plate. Cribriform plate is an important area for us, especially when we're doing endoscopic sinus surgery, because here it's a very thin bone, especially the vertical lamina of it. It's formed in 2 parts, which is the horizontal lamina and the vertical lamina, which is in continuation with fovea ethmoidalis here. And it is forming the roof of the ethmoid sinuses. And it continues again with the roof of the orbit, which is formed by the frontal bone. And when we are reading the CT scan of sinuses, we also need to be aware of the drainage pathways of these sinuses so we can understand the pathology a bit more. We know that the anterior ethmoid sinus, frontal sinus, and maxillary sinuses drain into middle meatus. Here we can see the middle turbinate, and the lateral to it, the aerated area is the middle meatus. Here it is the inferior turbinate, and the lateral area, the aerated area, is called the inferior meatus. So the 3 sinuses that I've mentioned are draining into this area. The nasolacrimal duct is draining into the inferior meatus. And in the next image, we can see the same things that I've mentioned with annotations. Here we can see the cribriform plate, the horizontal lamella. Here we can see the lateral lamina or vertical lamella and fovea ethmoidalis. Here we can see the nasolacrimal duct, which is draining into the inferior meatus. And I've just mentioned the frontal sinus is also draining into the middle meatus. There is a specific name for the channel of the frontal sinus drainage pathway, which is frontal recess. Here we can appreciate that. And here it's the first ethmoid air cell, which is called agernasy. And if we continue a little bit further, we can also appreciate lacrimal sac here. And we can see our ethmoid sinuses are forming. In this image, I'd like to talk about the osteomeatal unit, which is a common channel that the three sinuses are draining into. These are anterior ethmoid, frontal sinus, and maxillary sinus. Osteomeatal unit is pretty important for us, as mostly sinusitis, maxillary sinuses specifically, would be caused by a blockage of this area. We know that it's formed by 5 structures: maxillary ostium, infundibulum, hiatus semilunaris, and ethmoid bulla. So if we see here, this is the right maxillary sinus. The first opening would be maxillary ostium here. And then if we follow the tube, this little channel here, it's called infundibulum. Inferiorly, we would see the uncinate process, where we would remove when we're embarking on a maxillary antrostomy. And the second opening here would be hiatus semilunaris. Here, as I've mentioned, the fifth structure would be the ethmoid bulla, which is superior to infundibulum here. Again, before assessing, before when we're doing endoscopic sinus surgery, another important structure that we need to see is anterior ethmoidal foramens, because a very important structure is passing through anterior ethmoid arteries. If we damage these structures, we would have a very feared complication of orbicular hematoma. And here we can appreciate basal lamella, which is the boundary between anterior ethmoid cells and the posterior ethmoid cells. In this image, we can see the superior meatus and the superior turbinate. And we know the sphenoid sinus and the posterior ethmoid sinuses are draining into this meatus. If we go a little bit more posteriorly, we can appreciate the sphenoid sinuses forming here. The roof of the sphenoid sinus is called planum sphenoidale. Lateral to sphenoid sinus, we know the superior orbital fissure and the cavernous sinus is the neighbor of our sphenoid sinus. Here we can see the lateral limb of orbital fissure and the vertical limb of superior orbital fissure. And here we can see the right sphenoid sinus and the left sphenoid sinus. There is a septum between them. This is also important. We need to see where this septum is attaching to. Here we can appreciate here the anterior clinoid process. This can attach to internal carotid artery or to optic nerve. Therefore, we need to be very careful when assessing sphenoid sinus anatomy. Here we can see on the lateral sides, there is Vidian canals here, and the parts of sphenoid bones, medial pterygoid plate and the lateral pterygoid plate. And as I've mentioned, the position of internal carotid artery and the optic nerve is really important. Here we can appreciate optic nerves here, the indentations here. Internal carotid artery is on the lateral sides, and optic carotid recess is here in both sides. So these can be dehiscent, so we need to make sure that we assess the CT according to it. Here we see foramen rotundum on both sides, which entails maxillary nerve. And here we can see the Vidian canal on both sides, which entails the Vidian nerve. Another thing that we need to assess when we're seeing, when we're reading a CT scan, if there are any Onada cells or not. And here we can see a variation. Anterior clinoid processes are aerated, and optic nerve is actually in the Onada cells. Thank you very much.
Thanks, Aisha. Nice and short. Next presentation will be Shadi. Just try to be very short, and then we have Professor Hazan Pashak.
Good afternoon. I thank you for your attending our course. I would like to thank Ms. Aiden for her comprehensive lecture. So as we know, the most important cuts for sciences, it's the coronal. So just I will highlight for some points on the axial CT cuts for the sinuses. I will start my lecture from superior to inferior. So we start from the frontal sinus, as we see here in the coronal and the axial cut. This is the anterior table of the frontal. This is the posterior table. However, we can see here two intra sinus septum. So for this, it's very important to correlate this formation with the coronal cut, so we can differentiate which is the septum separate both sinuses, and if there is any frontal cell. So in this variation, we can see this is the frontal sinus. This is the anterior table, and this is the posterior table. However, we can see his cell, and if we colorate on the coronal cut, we can see this is the variation which is called intra-frontal sinus septal cell. So before I go furthermore, just I will highlight for the frontal recess, which is hourglass-like narrowing between the frontal sinus and the middle meatus. So in this, just I talk about this landmarks because I would like to mention that it's very close to the agar-nazi cell, which you can see it in the coronal cuts and the sagittal cut, which can lead to the drainage of the frontal sinus. So what is the agar-nazi? It's located anterior, lateral, inferior to the frontal recess. It's very important to identify this landmark, especially when we go to in the endoscopic sinus surgery to reach the frontal sinus, which is the most anterior sigmoidal cell. So in the axial cut, we can see here the septum. We start from the posterior sigmoid sinus, and this is the posterior sigmoid, anterior sigmoid. So the most anterior cell is the agar-nazi. So if we go lower in the sagittal cut, we can see this is the level of the sigmoid and the sphenoid sinus. So the sphenoid sinus in the axial cut. So this is the septum, and you can see this is the two posterior sinuses with the sphenoid sinus, which is very close to the optic nerve, and we can appreciate here the medial orbital wall or the lamina papyracea in both sides. So if we go for the third sinus, is the sigmoid sinus, which are the very thin-walled air cavities located between the upper third of the lateral nasal wall and the medial orbital wall. So it's divided to the anterior and the posterior sigmoidal cell by the lamina, basal lamella, part of the middle turbinate. And we can see on this sagittal cuts, we can see this is the skull base from the frontal sinus through the sigmoid, reaching sphenoid. And you can see here, we can appreciate here the agar-nazi. So, and I can go back again to the axial cut, normal anatomy. This is the septum, and this is the sphenoid sinus, and you see the sphenoid septum, and you can see this is the anterior and posterior sigmoid. You can appreciate the middle, the medial orbital wall, and this is the optic nerve canal. Now, the second point I would like to highlight is Onodi cell. So, which is the most posterior sigmoid cell, is located superior lateral to the sphenoid. So, if we see in the axial cut here, we can see we have three cells, the most posterior cell. So we cannot appreciate which one the sphenoid. So we should correlate on the coronal cut. In this cut, we can see this is. So this is the very small cell. It's the left sphenoid, and you can see here the right sphenoid, and this is the only cell on the right side, which very close to the optic nerve. Now, with the importance, my opinion, the importance of the axial cut is to identify very important vital structures with the optic nerve and the carotid, internal carotid artery is the optic nerve. This is axial cut, soft tissue window. We can appreciate here the medial rectus muscle, and this is the optic nerve, and this is impression of the cavernous sinus. And we can see here the bilateral optic nerve and the optic chiasm. However, it's very important to identify the optic nerve on the axial cut because the bony dehiscence of the optic nerve is reached up to 6.5. And this is the axial cut. We can see the sphenoid sinus and how the optic nerve goes through the protruded through the sphenoid sinus. Maternal carotid artery, we can see in this axial cut, this is the septum, this is the bilateral ethmoid cells, and this is the medial orbital wall. However, you can see this is the huge left sphenoid sinus, and you can see the impression of both internal carotid artery. And how we can correlate that information with the corner to identify which the intra sinus septum. And the percentage of protrusion of the internal carotid artery can reach up to 25%. Last sinus I would like to talk, it's the maxillary sinus. We can see the axial cut, normal anatomy. There's a septum. We can see this is the middle terminate. This is the superior terminate. This is the maxillary sinus. And you can see the behind the posterior of the maxillary sinus, you can see the vitreopalatine fossa, which can lead to the sphenopalatine artery. So this will lead me to the to highlight for this very important structure, especially when deal with the posterior epistaxis, the sphenopalatine artery. This is axial cut. We can see the septum. This is middle turbinate, and this is the medial maxillary sinus wall, and this is the posterior wall, and this is the sphenopalatine artery. Now this is the axial cut, septum, the inferior turbinate, level of the nasopharynx, and you can see this is the lateral and medial vitreopalatine.
We cannot receive this.
Sorry for that. So first I will go back to the sphenopalatine artery, which is you can see it in the axial cut level of the nasopharynx. So now, sorry. So this is the. Let's see. Yeah, so this is the maxillary sinus, this is the septum, this is middle turbinate. So behind the posterior of the maxillary sinus, we can see the sphenopalatine artery. Last point I would like to highlight this is the Heller cell or infraorbital ethmoid cell, which is can be found up to 35%. In the axial cut, this is the septum, this is the medial maxillary sinus, at which this is the position of the Heller cell, and this is the nasolacrimal duct. This is the navigation CT, so we can see coloration between the sagittal and the coronal with the axial view, and we can see here the septum, the concha villosa, lateral to it. You can see the anscent process, and lateral to it. This is the infraorbital osmoidal cell. And thank you for your attention.
Thanks, Shadi. Thank you, everyone, for your patience with us. Now it's a long day, and The next presenter is Professor Hazan Abshak. Are you there?
Yes.
Sorry for keeping you that
please.
So you're the last but not the least, and hopefully everyone will enjoy this presentation with you.
Yeah.
Should be now.
Good afternoon, everyone. My name is Hazan Basak. I'm coming from Ankara University Medical School. Today, I will try to summarize the anatomy of sinonasal cavity on MRI and also common pathological findings in sinonasal malignancies. We can go to next slide. Can we change the slides? Oh. Yeah. Next one. Why is imaging of sinonasal neoplasms critical? So sinonasal neoplasms are very rare diseases, only 3% of all head and neck malignancies. But all of these patients with sinonasal malignancies must be evaluated with some kind of radiological examination during the course of the disease. The imaging is very mandatory and important because we have to assess the entire extent of the lesion. So we can decide our management or our surgical strategies, surgical approaches, and to evaluate the critical structures, critical areas. Thank you. Many of the pathologies are in sinonasal cavities and sinuses are very, very aggressive and with poor prognosis. So proximity to vital structures such as orbit, skull base results with poor prognosis. So we have to assess these portions, these areas very well with CT and MRI scans. Next one. Imaging modalities needs a multidisciplinary approach. So we need an ophthalmologist, we need ENT surgeons, we need radiologists, we need neurosurgeons if we are dealing with a sinonasal neoplasm. According to various studies, there are many studies about CT on MRI on sinonasal cavity, and all of the studies are saying the same thing. We have to perform CT scan and MRI if we have if suspicious tumor in sinonasal cavity. So that means CT and MRI imagings are complementary modalities for us. We have to check for skull base, we have to check for brain, we have to check the pterygopalatine fossa, orbit, and palates to see the full extension of the disease. These radiological images not only detect the disease, it also we also needed to map entire extent of the surgical margins. We can go to the next one. Always we have to do with this CT scans and MRI reconstructions with different planes. It's very important because we can't see every part of the sinonasal cavities in every planes. So if we need to check the maxillary sinus, we need to check the axial, sagittal, and coronal planes. If we need to see the pterygopalatine fossa, we have to check definitely the axial planes. If we need to see the face, soft tissue of the face, then we need to see the axial planes. If we need to see the orbital involvement, we have to see the axial for the orbital apex evaluation. We need to see the sagittal images for the floor, orbital floor, and we need to see the coronal images to assess the floor and medial and lateral walls of the orbit. It's very important. Cribriform plate, we can see in sagittal planes the best. For ethmoid sphenoid sinuses, we need to see axial sagittal planes, and for palate, we need to see mostly coronal planes. This is very important to assess the extension. The next one. Computer CT, so computer tomography is usually first radiological modality. It's lower cost, higher availability. I just want to say, if there is a bony destruction in nasal cavity, skull base on orbit on CT scan, if there is a foraminal widening on CT scan, that means you are probably and most probably dealing with a sinonasal cavity neoplasm, so sinonasal cavity malignancies. Next one. Then we need an MRI to assess the full extension, to see the soft tissue structures. When we are performing an MRI for sinonasal tumors, you need axial coronal sagittal images, T1, T2 sections, and T1 with contrast enhancement images, mostly with fat saturations. That means you will have T1 coronal images with high signal on fat, but with fat saturations, you will get the enhancement better. You can see the enhancement better without having the destruction of the fat tissue. These sections should be very, very thin. And it is very having a decisive role for orbital fat involvement. It's very important. Dural involvement, dural changes, reactive changes, which we are calling dural enhancement, and brain parenchyma involvement. Next one. Skull base, when we are talking about skull base has 5 bonds, consists from 5 bonds. So that means ethmoid, sphenoid, occipital, temporal, and frontal bones. Next one. And there is 3 cranial fossa: anterior cranial, middle cranial fossa, and posterior cranial fossa. There are some bony margins of the fossas, but what you have to know is if you are dealing with a sinonasal neoplasms, that means you have to know very well the anatomy, radiological and clinical anatomy of anterior cranial, middle, and posterior cranial fossa, because the pathology can extend and involve all these 3 cranial fossas. Next one. So another issue on the skull base is the nerves and the foraminas. They already mentioned it in CT anatomy. I won't go very much in much details, but what we mostly check is some cranial nerves, such as ophthalmic nerves. Yeah, so I mean the trigeminal nerve. Other than that, optic nerve, oculomotor nerve, trochlear nerve, and abducens. These are the most common cranial nerves that we are dealing with when we are performing surgeries on sinonasal neoplasms. So what you see down here is that you can see the coronal weave of the sphenoid sinus with the internal carotid artery inside it, and we should also deal with median canal, foramen rotundum, which is very important foramina between cranium and sinonasal cavities, and we have to be sure where it is on CT scan. And median canal and foramen ovale is the most important structures we need to focus on when we are dealing with sinonasal neoplasms. Next one. When we are looking the paranasal sinus anatomy on MRI, it is actually very similar to what we see on the CT scan. This is a T2 MRI. As you can see, the most anterior part, we see the frontal sinus. You can see much more clearly nasolacrimal duct on MRI. And then we can see the structures like nasal septum, maxillary sinus. When we go further back, we start to see the orbit much better. And we can start to see the orbital extraocular muscles, such as medial rectus, superior rectus, lateral rectus, and inferior rectus, which is very important for us. So we can decide if the orbit is involved. And then also another important issue is to see the nerves. You can see far back the optic nerves, optic chiasms. You can see clearly the internal carotid arteries inside the sphenoid sinus, and it is sometimes also very visible to see the middle cerebral arteries and pituitary infundibulum and pituitary gland. When you go further back, you can see the basilar artery on the coronal CT scans. Next one. Oh, sorry, MRI scans. And for the next one, as you can see on the axial MRI, we can see the similar issues. We start to see the frontal sinus and structures inside the brain, such as ventricles and gyrus, gray matter and white matter. The next one will be the eyes. we can see the course of optic nerve very, very clearly, and the chiasm very clearly on axial images, axial MRI images. And then when we go down, we start to see the pterygoid muscles, temporalis muscles, masseter muscles much more clearly, which will give us some insights if the sinonasal neoplasm malignancy is involved the pterygoid muscles, if it is going inside the masseter muscles or masticator space, etc. It's very important. Far back, we started to see basilar artery at the posterior cranial fossa, and right in front of that, we start to see the clivus, middle part and inferior part of the clivus, and then we will start to see the vertebral artery inferior than that. Next one. On sagittal images is mostly important if you are performing neuroendoscopic approaches. So for example, if you want to see the entire anterior skull base, this is the bust. So if you want to see the cribriform plate, you can see it very clearly, as you can see here. If you want to do a pituitary gland, pituitary surgery, you can assess the tumor here. So, and it is very, very important to assess it if you are performing some kind of clivus chordoma surgery or odontoidectomies for trauma or something. You can clearly assess the skull base part, posterior skull base part better with sagittal images, and also the brainstem is very visible in sagittal images. Next one. Another issue is to see the cranial nerves, which we mentioned. It is not easy to see the cranial nerves if you have a tumor there. What we usually do is we are just checking the spaces, the places, the areas where these cranial nerves are passing, to be honest. So here we can see the trigeminal nerve and the mechal cap. This is very important part. And here on the coronal CT scan, we can clearly see the foramen ovale and foramen rotundum, where we can see, and the divisions of maxillary, so trigeminal nerves like maxillary divisions, mandibular, and ophthalmic divisions. We have to check these areas. Next one. What we have to look for deciding for sinonasal malignancies, if we suspect for sinonasal malignancies, is first we have to know enough evidence is not possible with only radiological imaging. So there should be always a histopathological diagnosis. But if we see one-side involvement, if we see a large soft tissue mass with contrast enhancement, and if we see a necrosis inside us, if we see bone erosion on the CTs, destruction, if we see it is extending to other compartments, if we see a perineural split, so perineural invasions, or if we have a lymph node metastasis, that means we are probably dealing with a sinonasal malignancy. Next one. What we have to know is when we check on a CT scan or even in MRI, sometimes the trapped secretions can be very, very tricky to decide if there is a tumor inside there or if there is a fluid inside there. So what we have to look is T2 MRI, because T2 has high signal on water and fat. And if we have to check always on MRI if we are dealing in neoplasms on T2 sequences, so we can decide if there is a trapped secretion inside it. Next one. Perineural split is a common thing. Bone destruction, for example, on CT scan, we can see bone destruction, but there are other diseases such as Wegener or cerebrospinal mucosis causing the same view like a sinonasal tumor. So we have to be very careful when we see just bone destruction. Just don't go just like it should be a malignancy or something like that, only just seeing on CT scan. Next one. Perineural split is very common, especially for adenoid cystic carcinoma, but we can see it also commonly in melanoma and lymphoma. Next one. There are many neoplastic lesions common in paranasal sinuses, like adenoid cystic, squamous cell carcinoma, lymphoma. Next one. What we see is if we are suspecting of anterior cranial fossa extension, how we decide that? There should be loss of sharp, low signal of the bone on cranial CT or PACE CT, paranasal CT, loss of low signal on periostal interface, displacement of dura on MRI and CT scan, thickening of dura, which we call the dural enhancement. As you can see, the left side image, you can see the thickening of the dura. There could be an invasion, brain parenchyma invasion, as you can see on the right side. In right-sided image, show it very clearly, the invasion of the brain parenchyma. There could be some subarachnoid space obliteration with CSF contact, or displacement of the dura. Next one. We should always check, if we are suspecting of sinonasal malignancies, we should always check the lymph nodes of the neck. I think they mentioned it before. Next one. When we check the sinonasal malignancies, first of squamous cell carcinoma. Squamous cell carcinoma is mostly the most common sinonasal malignancy. It is located mostly in maxillary antrum, inside the maxillary sinus. You can see here an example of this case. There should be, characteristic is, there should be aggressive bone destruction, and there should be a necrosis, intratumoral necrosis. But other than that, radiological findings are non-specific. So you can't just look to MRI or CT scans and decide that it could be a sinonasal squamous carcinoma. Next one. On MRI, if you are looking for sinonasal squamous cell carcinoma, there should be low signal in T2 because of the cellularity, and there should be lesser enhancements lesser contrast enhancement of the T1 compared to adenocarcinoma or olfactory neuroblastomas or melanomas. So, which means that esthesioneuroblastoma and melanoma are also highly aggressive tumors. If there is a lesser degree of enhancement on CT scan, on MRI scan T1, that means you probably deal with a squamous cell carcinoma. Next one. Squamous cell carcinoma, like I said, it's very aggressive. We have to check on MRI all this areas like nasal cavity, premaxillary area, then posteriorly pterygopalatine fossa, laterally masticator space, superiorly orbits, skull base, and always check for perineural tumor spread. Next one. Adenoid cystic carcinoma is the second most common sinonasal malignancies. It has a predilection also, again, in maxillary region. We commonly see it in maxillary sinus. Even if the tumor is very, very small, if you can detect it very well, that could be, and that should be mostly, perineural tumor spread, perineural invasion. So on CT scan, you will see the widening of the foramina. Here on the above scan, you can see the widening of the infraorbital nerve canal, and down you can see the contrast enhancement of the area of the infraorbital nerve. This is highly suggestive of perineural tumor spread. And if you have a perineural tumor spread on sinonasal MRI or CT scan, you have to first think about adenoid cystic carcinomas. Next one. This is an example of a case. It's, as you can see, it is contrast enhanced. It's causing the enlargement and invasion of the pterygoid muscles. As you can see, go all the way back. And if you only check the CT scans, you can just have, you can't be sure that it is invading the pterygoid muscles that extensively, but on the MRI, you can clearly see there's an enhancement and invasion of the pterygoid muscles. Next one. Adenocarcinomas also rare malignancies. It is this time we are seeing adenocarcinomas mostly on sinonasal cavity and ethmoid sinuses. This means it is mostly seen on midline. So this is a midline tumor, I would say. Imaging findings, there is no characteristics. Characteristics are non-specific. So you won't have a characteristic view for adenocarcinomas on the imaging, or either CT or MRI. What you can see is poorly defined mass inside the ethmoid sinus nasal cavity, and most commonly having skull base involvement. Next one. On MRI, we will see on T2 sequences, typically intermediate to hyperintense, but it is not characteristic. So we can't decide anything with that one. On T1 contrast images, heterogeneous enhancement, but fat saturated contrast images may help us to detect the perineural spread. It is not as common as adenoid cystic carcinomas or other tumors, but it is possible to see perineural spread on adenocarcinomas. Next one. Olfactory neuroblastoma. These are one of the important tumors. It's very rare, but it is also a midline tumor, like adenocarcinomas. It is mostly arising from the olfactory neuroepithelium at the level of cribriform plate, which we see on the CT scan before. So it is characteristics finding is it is a dumbbell-shaped tumor. So at the level of cribriform plate, it looks like a dumbbell. So there is a waist at that level at the cribriform plate. Another characteristic findings is there is usually a intracranial tumoral cyst. So that means if you see a tumoral cyst and dumbbell-shaped tumor, you are probably dealing with olfactory neuroblastoma. This is a very important findings and characteristic finding. Next one. CT findings, as we can all think, the bone remodeling, there should be bone destruction, bone remodeling, so it can go inside the intracranial cavity. There should be homogeneous enhancing mass and necrotic tissues, necrosis inside the tumor. Next one. On T2 MRI, intracranial cyst is important. You can see this intracranial cyst, intracranial tumoral cyst, better in T2 wide images. You can see some examples of olfactory neuroblastoma here. Next one. There are sarcomas. Sarcomas are very, very difficult to decide. They are very aggressive tumors, and it is not possible they have no characteristic findings. It's impossible to differentiate it from sinonasal squamous cell carcinomas or other undifferentiated tumors of sinonasal cavities. Next one. Chondrosarcoma. There is specific findings for chondrosarcoma, on which you can see on CT scans. They have a chondroid matrix calcification. So you see a calcification inside the tumor, so ring-like calcification on CTs, and low T1, high T2 intensity on MRI. If you see this T, it may help you to decide it could be a chondrosarcoma, but it is very, very rare tumor on sinonasal cavity. Next one. Osteosarcomas, as we all can expect, it is also having, the CT scan is having much more meaning for diagnosis of osteosarcomas. It has a hyperdense mass with osteoid matrix and periosteal reaction. This is a typical reaction, which we call sunburst periosteal reaction. We see osteosarcomas mostly on mandible, but it is very rare. We could see it on maxillary. Malignant melanomas, it's very rare tumors. It's very aggressive, highly aggressive. At the time of diagnosis, most of the cases has lymph node metastasis. So it would help us to decide maybe melanoma. It would help us to diagnose melanoma. Imaging characteristics is not too specific. It's like all the aggressive tumors we see on the sinonasal cavities. There should be a soft tissue mass nasal cavities. It has a predilection inside the sinonasal cavity. More than sinuses, we see it mostly inside in nasal cavity. predilection for nasal septum, lateral nasal wall, and inferior turbinate. Perineural spread, perineural invasion is common. So if it is not adenoid cystic carcinoma, it means it is malignant melanoma, most probably, if you see perineural invasion. Next one. Malignant melanoma, CT findings, we will only see bone destruction and aggressive soft tissue tumor. On MRI, we can see high signal on T1 images due to melanin, ions, and hemorrhage. And T2, we can see low signal, but it is not it won't help us to decide, just it could be a melanoma. Next one. Lymphomas are very rare, and it is non-specific imaging features, so it is impossible to decide if it is a melanoma, sarcoma, or squamous cell carcinoma, just checking on CT and MRI images. Some the lymphomas, like B cell type and T cell type, have some special findings on CT scan, but it is not that much useful in clinical settings, I would say. T1 images, contrast images, we can see homogeneous and diffuse enhancement, but it is, like I said, like a very, like in every aggressive tumors in sinonasal cavities. Next one. Sinonasal undifferentiated carcinoma, like I mentioned before, the others, and this is also it doesn't have it has non-specific CT and MRI findings. You usually see it also in the midline, like olfactory neuroblastoma and adenocarcinomas. It's very difficult to differentiate it from olfactory neuroblastoma. They are really aggressive mass with bone destruction and rapid growth, large expansive lesions. ISO intensity on T1 with muscle and low to intermediate signal on T2 can help with diagnosis, but we see also heterogeneous enhancement with necrosis. But like I said, it's not characteristic findings. They don't have characteristic CT and MRI findings. Next one. Another important part is imaging in postoperative period. There is no standard protocol for this post-treatment surveillance. We have to compare it with preoperative imagings. Usually, as we know, we always perform endoscopic examination in 1 to 3 intervals. MRI imaging is important every 3 to 6 months for the first 24 months. And beyond this, we are performing imaging every 6 months yearly. We prefer, if we are dealing with sinonasal malignancies, we prefer to perform MRI imaging. But if you have a PET CT scan, if you have access to PET CT scans, it can be helpful between 6 to 12 months. However, PET CT has a unique role in tumors such as melanoma. For melanoma cases, I highly recommended to perform it post-operative period. Next one. This is a case which you see. So this is a melanoma case. This is preoperative and post-operative PET scan views. Next one. To conclude, we are performing radiological imagings, usually CT and MRI, both of them for sinonasal malignancies, but it is very difficult to decide to have a precise diagnosis with only radiological imagings. But it helps us to see the tumor locations, extensions, growing patterns, and contrast enhancement patterns. Still, we need different tools to get a precise diagnosis. For features, PET MRI can be useful. There is a new imaging methods which we call PET MRI, maybe, but more studies needed. There's not too much study, but maybe in future we will use it for diagnosis and follow-up purposes. Thank you very much. I can't hear you.
Sorry, I was just thanking you for your patience this 5 hours with us. And thanks everyone for listening as well. We're gonna have a hands-on ultrasound Amy Bones. So I don't think so that it will be suitable to do it with the team's video as well. So or you would like to share it online. Can we do basic showing and then when we start practice, we just say thank you for just showing the machines what it is, like starting with the basic things. What is the machine? How it works? What is the principles? And then we can say thank you for everyone. I'm not quite sure how to do this. If it's possible, it'd be great. The scan.
Then we refer to the
ENT.
ENT in Lincoln.
Okay, am I good to go?
Go for the gold standard if you are
Yeah.
not.
Can anyone just can you see?
Can you hear me?
Can everyone hear Emmy? No, I cannot see. Why? Can you check Ahmed in the computer? You can see it in the computer, yeah? That's fine, sir.
Okay.
It's here. So there is camera here. Would you like to connect this?
No, just.
No, that's not gonna.
Okay, yeah.
Yes.
It should be here.
So long as you can hear me okay, I'm going to do a whistle stop tour through an ultrasound scan of the neck, because ultrasound is obviously, although we give you some still images, it's best viewed dynamically. And it's really useful in the head and neck, sometimes gold standard as for thyroid imaging, but also for use in diagnosis, surveillance, and for recurrent disease as well, especially where lymph nodes are involved, because we have the ability to basically the chin all the way down to the hyoid bone. So if you just wiggle your tongue for me, so we can see the tongue here. So if there was a base of tongue lesion, you might be able to see on ultrasound. And here's the back of the genioglossus here, and we can come down a little bit further, and we also catch here the hyoglossus muscle. So this is the mylohyoid muscle, this is the hyoglossus muscle. This is an intrinsic tongue muscle, so this one will move with the tongue. So just wiggle your tongue again. Yeah, so you can see that. Okay, and then we come down to the hyoid bone, which will shadow because all the sound is being bounced back up towards the transducer. So that's the first sweep. If we come a little bit laterally, we will see, so I'm coming round towards the left side. We can see the submandibular gland here, the mylohyoid and the hyoglossus. So the submandibular duct will pass between these two, and if it's dilated, that's where you will look for it. Just inferior to the submandibular gland is the tonsil. And again, you wouldn't see a small tonsillar tumor, and we wouldn't use ultrasound for staging of oropharyngeal cancers. But if there is any associated lymphadenopathy, we would, in level 2, then we would certainly look at the tonsil and the base of tongue to see if we can see any abnormality there. So we would assess this nice homogeneous middle grey
gland here, which, like I say, is the submandibular gland. So if we tilt up towards the mandible, this is the mandible just coming in here. So between the submandibular gland and the mandible is the level 1B lymph node. So the anterior belly of digastric is medial, so it's lateral to the anterior belly of digastric between the submandibular gland and the mandible. If I turn my probe, just see those two areas there, so we can see the submandibular gland, node, mandible. Coming laterally, this is the posterior belly of digastric muscle. Posteriorly, so behind the mandible here, angular mandible, we're seeing the parotid gland. So this is the tail parotid. We don't see the deep lobe very well because of the shadow from the mandible, so we would need MRI to see the deep lobe of the parotid gland, but we can see beautifully the superficial lobe. If we scan through there, got intraparotid lymph node here, which looks very normal. And as we were talking earlier, some skin SCCs can metastasize to the parotid gland. So if that was involved, that would be easy to access for a biopsy on ultrasound. So this is where I've turned the probe, the posterior belly of digastric muscle, and this is the parotid tail, and this is almost like a sagittal image of the parotid tail. If we come back into transverse or axial, this is the mandibular gland here, so we've come just posterior to it, and this is our level 2 lymph node, or level 2 lymph node. And we can also see here the bifurcation of the parotid. Just see that come together. And then, like we were saying earlier, we can't really on ultrasound differentiate between levels 2A and B, but the more posterior we go, that we know roughly that we're either in A, which is medial, and B, which is lateral, but we can't use the same nerves that you would use surgically to be able to tell where that is and differentiate between the two very clearly. But at the top here, we've got the sternum muscle. So level 2 goes as far as the posterior edge of the sternum muscle. Followed down, and once we get to the level of the hyoid bone, which is, so we can use one of 3 markers. So we can come medially and look for the hyoid bone, which is here, or we can roughly use the lower edge of the submandibular gland, or roughly use the bifurcation of the parotid, but you've got to understand that the bifurcation of the parotid is variable. So if you want to know for sure, you need to come more medially, look for the hyoid bone, and then come lateral again if you want to differentiate between level 2 and level 3. So once we've passed the hyoid bone, we come into level 3, and again, that's the same lateral border, which is the posterior aspect of the sternomastoid. So this is all level 3. See in the carotid sheath, if I take a bit of pressure off, the carotid artery, common carotid artery, the internal jugular vein, which is a little bit collapsed because I'm pressing, and we can also see the vagus nerve there. As we keep coming down, we get to the strap muscles, and the important one in this area that we were talking about earlier is the ulnar hyoid. So we can see this really clearly on ultrasound. We can't say much on CT and MR, but we can use it as the marker between levels 3 and 4 on ultrasound. If you're unsure whether it's the ulnar hyoid or not, you can come medially and look for the lateral border of the cricoid cartilage, which is the tip. So once we've gone past the ulnar hyoid or the cricoid cartilage, we're into level 4. And we come all the way down to the subclavian vessels. That's level 4. Okay. So level 5 is posterior to this posterior edge of the sternomastoid muscle. So these are transverse processes, so it is from this area and anterior. So level 5 is easily palpable because there isn't as much muscle coverage as the other area because it's posterior to the sternомatoid. So level 5 is lots of patients will palpate normal level 5 lymph nodes. We can also see in this area the scalene muscle. So that's the medial scalene muscle, that's the medial scalene muscle, and in between here is the brachial plexus. So that here is the brachial plexus, and that sits in the intrascalene groove. And you need to know this on ultrasound because if you get something like a nerve sheath tumour that's sitting there, it shouldn't be mistaken for a lymph node. Ideally, we don't want to be popping a needle into them. Okay. So if we come medial again and come back to the level of the hyoid bone, hopefully we'll be able to see some of the line. So here is the follicular. Those little white, look like little thumbnails. As we come down, we can see the thyroid cartilage, and we can also see here this bright area just underneath the thyroid cartilage. That's the paraglottic fat, or false cord. And then we might, in some patients, you can see the true cord. Which very easily today. But once you get past the paraglottic fat, then you can sometimes see the true cord there. You can just see maybe the arytenoid on this side. As we come down, we will then get to the cricoid cartilage. We can't see the posterior aspect of it, we can see the anterior aspect of the cricoid cartilage there, and then we will get to the thyroid gland. So 2 lobes, no thyroid nodules here. So right lobe, isthmus, left lobe. Also see the trachea in the middle and the esophagus just sitting to the left-hand side there. And then, like I say, we can see the carotid artery and then the internal jugular vein on both sides. Carotid artery, internal jugular vein. So level 6 lymph nodes are in the midline, so either side or in between the carotid arteries. So this is level 6. It comes all the way down. We can't see level 7 on ultrasound because that's when we would get to the head of the clavicles and the sternum. So we can't see. We would need CT to have a look at level 7. As we come back up and back towards the carotid gland, we can also see the masseter muscle here. So if there was any duct dilatation from the carotid gland, you would see a dilated duct sitting over the anterior aspect of the masseter muscle. And that drops off just at that free edge of the masseter and then pierces the buccinator, which is this muscle here. You just blow air into your cheek for me. So you can just see a tense buccinator muscle here. Just blow a bit more air for me. And then some air against the mucosa, which is the white line. So the black line is the buccinator, the white line is air against the mucosa. And then just put your tongue on the side of your cheek for me. We can also see the tongue quite clearly through the cheek. So you can just see the midline raft there. Hold on. There we go, a midline raft through the tongue. So if there was a lesion on the tip of the tongue or on the lateral border, you can sometimes see that on ultrasound. That is a bit of a whistle-stop tour through the anatomy of the neck. And I think just seeing as this is a head and neck workshop, I think coming back to level 2 is important because the areas that we can see, or some of the pathology that we can see in that area, as well as lymph nodes, because the carotid bifurcation sits here, we need to remember that there could be carotid body tumour as well. And then also schwannomas from the vagus nerve. So ultrasound is really useful for looking at the anatomy, but we can very easily call out normal anatomy. And so long as we have an idea of pathology in the neck, we can likely decide what whether to do a fine needle aspiration or a core biopsy when we do see pathology. So if we saw a level 2 lymph node which we thought was metastatic from squamous cell carcinoma, we would want to do a core biopsy because we would want to know the P16 status. And likewise, if we were considering lymphoma to be the diagnosis, we would also need a core biopsy because we need to be able to subtype that as well as diagnose lymphoma. So that's a normal scan. I have just got, if you want to go through, do you want the slide with the pathology? Or
Yeah.
it's literally just a couple of minutes.
I can volunteer as well if anyone wants to do.
And you'll have a scan.
Yeah. And if you want
There we
to
go.
guide those people, but
Yeah.
gentle, yeah.
Who wants to have a go?
Very, very gentle.
Yeah.
Any incident that probably don't want. Don't mention it.
That is.
Again. Breaking my confidential over the internet now.
Anything to press here or just?
So just have a bit of gel on the probe. So that's the coupling gel. So we need that to emit the air so we can get the sound to go from the transducer through to the skin, the tissue. If you just go up a little bit higher, you're demonstrating very nicely a level 1A lymph node there. Just come a bit, so you need to move your probe that way slightly towards the right. So there's your mylohyoid. Anterior belly digastric, just move to the right a little bit more. Down, and sort of, yeah, little level 1 lymph node there, look. Looks completely normal.
I have one here for level 5, large one.
Oh,
one-
yeah.
1.5 centimeters.
Yeah, they're really
At
easy
the
to
normal.
feel in level 5.
Yeah.
Oh, always normal.
That's more.
So then you can see if you just move over to the right a little bit, wait, sorry, patient's left. Right. So you can see the base strong, you're just coming to the hyoid bone there. Oops. Doing some measurements.
Is a tongue is.
Yeah. So you can see that if you wiggle your tongue around, you'll see that moving. And you'll get down to the hyoid bone, and then you'll get the shadow. So now you're down to the thyroid cartilage.
It's a high bone.
A bit higher. Yeah, so there's the hyoid bone. So if you saw a lesion around this area, you'd be thinking thyroglossus duct cyst. So now we're at the thyroid cartilage. So come down a little bit more, you might see. So they're the false chord section.
So how does it appear as a lesion? So how do I identify a lesion? It's supposed to be this is not viral. Yeah. In general, for example, it's okay with thyroid gland. I can see a
Yeah.
lesion with a thyroid gland, but in the space between hyoid bone, some other gland, or whatever the way. So it will be rounded, just disrupted anatomy.
Depends what it is. So you want to, that's why you want to know your lymph node levels, because it will likely be a lymph node.
Yeah.
And that's probably the next thing that we would say. Whereas if it was in the floor of mouth, you would be thinking granular or again.
Yeah, yeah.
It's thyroid, right? Which is business fine.
Just
Got
pure
it.
cystically.
Yeah, so it depends on the patient. What about, yeah.
After it, so in the lateral neck, I would be thinking, first of all, is this a lymph node?
Okay.
But then what you want to be thinking is, where's the anatomy? What's it doing to the anatomy? A bit like the parapharyngeal space. If it's pushing the submandibular gland down, it'll be a level 1B lymph node. If it's pushing the vessels, so the bifurcation of the buttock down, it'll be level 2 lymph node. If it's pushing the vessels outwards, a little bit more suspicious. I'm thinking that's actually a carotid body tumor.
Yeah.
Or if it's pushing the vessels upwards, I'm thinking that might be a vagal schwannoma. So it depends. So once you've seen the mass, which will be once you've got an idea of the normal neck, seeing something abnormal will be easy.
Yeah, that's the point.
There,
My main question.
yeah, you will be able,
Yeah.
you'll notice.
Yeah.
And then you need to be able to think, well, where's the anatomy? What's it doing to the anatomy? Then what's the differential diagnosis? And then you've got
Can you see the lymph node?
It seems
a bit much out.
Definitely
Oh, yeah.
haven't seen what's there, so we need to do like.
Yeah. So where are you? So you are,
starting to
Can you feel the lymph?
so this is the masseter muscle. Just here.
anterior text would be the duct.
So you'll see the duct over the anterior aspect of the masseter muscle. If it's dilated, just come backwards a little bit. There we go. So you won't see the duct because it's not dilated, but you'll see the duct come from the as you. So there's the parotid gland. Oh, we've got a little ectopic parotid bit of tissue there. So that's normal ectopic parotid tissue. So some patients will feel that as a lump. It's normal. No, it's just the anterior aspect of the masseter muscle. So look, it's not connected to the main.
In the ear, and there is a bit.
There's a bit of a gap, and then there's a little bit of tissue. But look, it has the same echogenicity. So we would use echogenicity as the descriptive word for ultrasound, like intensity for MRI and density for CT.
So having said that, then one should do too many ultrasound to be oriented with the normal anatomy in order to be able to make outlook like that.
Feel free to do it rather than start looking at abnormal and trying to figure out what it is.
Here or
Definitely start with the normal
Right.
and your anatomy.
is that the lymph node, this one?
No, that's just either some muscle or soft tissue. So
Not the-
have a bit more gel. So if it's level 5, you need to find the sternomastoid muscle and then go posterior to it. So nice little nipple there. So there's the back edge of the sternomastoid muscle. So this is spine, taking this transverse process is here. This is muscle. So that's the lymph node.
This one.
Yeah.
So
So it's oval. You don't always see. So in a textbook, it will tell you will see a bright fatty hilum. You won't always see that in a normal lymph node.
If it's especially chronic for a long time, this is 25 years.
So this is just a normal sized lymph node, just easy to feel because it hasn't got the muscle coverage. Just go back to the carotid sheath there. Right, so yeah, that's really nice. So there's the carotid, just move your approach away a little bit. So common carotid, internal jugular vein, just bounce on that a little bit. So see how when you push on that.
if you like to look to the other screen and get it right here.
You could just see the vagus nerve really nicely. Yep, so there's the vagus nerve. So here's the vagus nerve, across sheath, carotid artery, and the internal vein. So just take some of your pressure off the probe and you'll see the vein fill. So one of the things you need to be careful of when you're doing a biopsy is that you don't collapse that down too much and then think, oh, I'll just put my needle through there and then realise that you've gone through the IJV. So it's the same with sometimes the external jugular vein is very superficial. So that'll be this part, the scalene muscles, yeah. So the brachial plexus will be between the. So it looks like. Your two, I think the two lateral more, a little bit more too. It would be between the medial and the middle. Yeah. Down a little bit. This is sternomastoid. So sternomastoid just here. Oh, here, okay. Oh, so here's your hit there. Those 3 traffic lights, like 3 black dots here.
Yeah.
There. One. Oh, just take it that way again. So that's the interscaling groove.
So this is the brachial.
Brachial plexus, yeah. And again, important to know, so you don't need to see it on every patient, but if you get a lesion in level 4, then you want to know. That's a little bit more lateral, then you probably would get, say, a metastatic lymph node from a thyroid cancer. But you just want to,
You can see the jugular carotid
Yeah.
thyroid.
Yeah. you just want to make sure that it's not associated with that, especially if it's a solitary lesion.
Yeah, this is thyroid.
Yeah, because I haven't seen it, sorry.
Yeah, this is thyroid.
So, do you want me to scan?
Yeah.
You want hands on the,
Yeah, you
swab
can
with
have a
you,
look.
Abdurrahman.
So there's,
Abdurrahman, you want hands on, I can swab with you?
this is the thyroid gland.
Hmm?
So again, another normal thyroid gland. Trachea, esophagus.
I used to do it by myself.
Oh, did you?
Yeah, I went to,
You don't need-
I used to do some, no, they used to do some like charity missions, so.
That's the anterior belly digastric. There's the mylohyoid, geniohyoid, you see really nicely. Sublingual glands, which you can see really nicely. And then this is the glossus, which you should see coming all the way at the base of tongue there. So if there was a big base of tongue lesion, you would see it. And then something laterally. So this is the submandibular gland, mylohyoid, hyoglossus. If there was a dilated submandibular duct, you would see it between the two muscles there. And if you come down a little. That's all it. So you can see base of tongue, tonsil, submandibular gland, the angle up. That's a level B lymph node. So I know the anterior belly of digastric is over here. And I'm lateral to that. I'm above the submandibular gland. So I know that's a level 1B lymph node. We go posterior to the submandibular gland. Yeah, that's a level 2 lymph node. And that's really nice. So it's elliptical, it's got a bright center, the hilum, so hypoechoic with a hyperechoic center. Like I say, you don't have to see the hilum to call it normal. And we would, let me freeze that. Then we would want to measure it in its maximum short axis. Okay. So you'd want to measure. That's not very accurate. Sorry, I'm used this machine before, so I don't know how it works. Can we leave that one again?
What is what I had.
Just to, so you want to freeze that. Measure distance. It's not very accurate, but you want to measure that short axis rather than that long axis. You don't want to be measuring a normal lymph node from this side to this side, because it will just sound bigger than it actually is. Who wants to go?
Would you like to? You need any more volunteers?
So actually, I need the ultrasound whenever I have a small nodule that I cannot find. I need to get the labs.
Yes.
So this is where I feel that I need ultrasound.
Yeah.
So I'll be more than grateful. You just orient me.
Yeah,
What
absolutely.
is the medial, lateral, superficial, and the
We scan it?
yes.
Scan it?
I believe that
So the first thing you need to do, you need to make the basics of some ultrasound physics, because things that are stick in the neck can look solid on ultrasound, and things that are solid in the neck can look cystic. So typically lymph nodes that are the patient has lymphoma will look cystic, but they're not. They're solid. So
How soon?
Reveal users. How can you say this?
So the reason it looks cystic is because of the impedance, how quickly the sound is traveling through to the tissue around. So it's very physics based.
Yes.
But the thing with practice is you'll get a very bright posterior enhancement because the sound has travelled very quickly through that area without being absorbed or reflected or anything. Whereas if it's a pseudocystic lymph node or lesion, you might get a bit of brightness behind because of the impedance, but it won't be bright behind. It will just be a little bit brighter. And I think that's just a case of having a look at you and seeing. Yeah. But what?
Of course,
I mean, it's hard, isn't it? And then the other thing is that you just want to know where the vessels are.
Yeah,
You're
sure,
obviously
absolutely.
just
Yeah,
going
yeah.
through those. And you can pretty much. Yeah.
Of course.
Have a good week.
The season.
So everybody knows that even just by feeling where the carotid and the IGB, the things that you just want to look out for is the external jugular. That's very superficial, and you're not going to be doing any harm to the patient, but you're going to have to remove the sample, which will affect your ability from that sample and also let the press for a bit longer. Okay, right, where did that big tube of gel go? It's just in there.
Yeah.
Oh, yeah. And then the orientation of the probe.
Yes.
So you will also have, so you want to keep the probe with the, there'll always be either a thumb mark or a little ridge on the side of the probe you want to keep towards you or the patient's head. So your head or the patient's head. As soon as you turn it anywhere else, your orientation will be wrong. And you should, in theory, just put the gel on there for me. If you've experienced scanning, you will know that quite quickly because I expect, so if I move here, I expect to come to the right of the patient. And if I go from here, I expect to go to the left of the patient. If I turn my probe, if I go there, oh, it's moving the wrong way. Do you see? Yeah. Whereas I expect it to come this way and it's not, it's going that way. So if you have a go and move that way and then move that way and then turn it round, you'll know you're coming to the right side, but actually I'm moving to the left. So if you have a go and do that,
This
you'll
mark
get the
was
be towards you or the
towards me,
patient head.
right?
The other way. And then turn the probe around. So you want to come, yeah, do you see? So you will still get an image, but it's flipped. Yeah.
Right. So this smart toward me, right? Okay. So this is the superficial.
Skin.
Okay.
This is the patient's back.
Oh.
This is the left. This is the right. So skin's fine, left, right. If you're holding the probe like that. The only other way really you should hold the probe is like that. And then you've got patients. So just move up for me so you can check. So patient's head, patient's feet, and then skin and spine. So if you're thinking, okay, which am I going anterior or caudal, or cranial or caudal, just move it and you will know. So move just slide the probe up. So you're going towards the chin. So that's cranial.
Yeah, sure. So what would you advise for visualizing?
Most of my scans and all of my biopsies in the transverse, so that's your axial plane. So you'll see much more anatomy if you're in the axial plane. If you're in the sagittal or longitudinal plane, you'll see much less. You will only see what one strip. Yeah.
Okay, right.
So if I'm trying to decide the shape of something or the extent of something or take it a volume, then I will go into longitudinal. The other thing is it's good for vessels to turn in longitudinal to see if it's got an end or whether it's a linear shape, because if the internal jugular vein is thrombosed, it can look like a lymph node.
Right. and it's always should be perpendicular to the skin.
Yeah, so you can, the good thing
Oh, it
with
shouldn't
that
be
is
like-
you can tip, you can rock, you can twist. But what you want to make sure is that no matter how much of that you do, which is all really useful, what you don't want to be doing is that.
Right. So I think that the key landmark should be, in this case, is the SCM, isn't it?
Yeah,
This is
so-
the one that I should.
So
look for.
you'll always find the FDM. Yes. So what you might want to do, so from an orientation point of view, you might want to start in the midline because
So
that's
this is-
where most of your anatomy is, and then
Oh.
naturally, that's what I would do. So if,
So-
say if the patient has had surgery or an anesthesia registrar, I would say go back to the midline, find something you can see, and then come naturally.
So here we have the main blood vessels.
Yeah, so the carotid, and that's actually the bifurcation. If you just sweep through that, and yeah, see that coming together. So that's generally in most people at level 2, but can bifurcate lower.
Okay, so
higher.
say that this is, I find that SCM, then I have
Yeah, there's SCM.
go other
It's
down.
fine. So there's transfer. You just saw transfer process just over there. So the useful part of the soft tissue of the neck is all anterior to that.
So if I'm looking for a lymph node, level 3, it should be.
So
Which
it
is
should
okay.
be, yeah, so it should be between the hyoid bone and the cricoid cartilage, or the bifurcation and the armor hyoid. Which again, like I say, can vary in bifurcation. And they sit here in the fat. So that's muscle, that's carotid sheath, that's muscle, that's spine. So they sit here and then they expand. And then they'll sit just along.
So say that I found the lymph node at this level.
Mhm.
So now if I put a mark,
Mhm.
so the mark should be on top of the broad.
You're then going to biopsy it.
Yeah, exactly. So I'm talking about taking.
So
a
if I
snapshot.
go to theatre and do a surgical marking,
So sometimes it happens with us that we use the ultrasound
to find it.
in the theater. So
Yeah.
Yes.
So I would probably, so I would come and mark it. So say we are marking. Haven't got any lymph nodes in the neck. Say we're marking this area. So you're marking that area
Yeah.
there. I would bring it to the edge of my probe here. Or you can bring it to the middle and mark there, but you're going to be a little bit higher.
Exactly. So this is what.
So what I would do is get into the middle of where I'm trying to mark. And then bring it to the edge of my probe, which is here. And you can just, oh, I'm scanning the wrong way. Oh, let's use the carotid, it's not. So I would bring it to the edge of my probe here, and then I would mark
Okay.
it there.
I see.
Because I know I'm at the right level.
Yeah.
I mean, the carotid obviously is going up and down. But that I would mark it there, because if you mark it here,
It's
you've got
higher.
to give yourself another.
Yeah,
couple of
a bit
centimeters.
higher.
Yeah, so to be a bit more accurate, and obviously you want your patient in the position first.
Yes.
As soon as you extend
Yeah.
their neck, obviously it's gonna be easy.
Well, so we use it while the patient was asleep. So
Yeah, yeah.
yeah, actually in cases of not palpable lymph
Yeah.
nodes.
yeah. Or if you have a friendly sonographer, you can get them to come and.
Would be much easier.
Do you want to have another little go? So it's about-
That's fine.
about the-
Yes, by the way.
You don't need the shirt again, do you?
So now the market would be. So again, here we have the CM.
The thing with the SEM though is it goes down the whole neck, so you can't tell which lymph node level you're
Yes.
at, just like the SEM.
Yeah, absolutely. Yeah.
Yes. So if trainees send me an image and they have an image like that, I'll say, well, I don't know what level you're at. I can see the anatomy, but you either need to label it for me or give me a bit of anatomy that I can then see.
But
So
you're
if there's a bit of submandibular glands on there, I know it's that level 2. If I can see that on the hyoid, I know it's either level
To sort of behind the.
So you want to keep going, so you just at the same level up. You want to go round the neck somewhat. More posterior than zinc, keep going around. There you go. This is level 5.
So
It's very
how,
superficial.
how do you?
So there's the back edge of the sternomastoid.
Okay, I see.
The trapezius will come in here, and you'll have your scaly muscles behind there.
So
Fine. Yes.
this is the trapezius.
Let's go, keep going further back. Yes,
Close that.
trapezius there.
Pretty go.
See that on the high edge there.
Mm.
There's the thyroid gland.
Yeah.
So the anatomy is all there, and you've got to kind of piece it all together.
Yeah.
Also, that needs practice.
Yes,
Yes.
yes. And what you want to be doing is sweeping from the top to the bottom, because
Parotid.
it
Focus on the parotid.
so that's masseter, that's mandible, that's carotid.
So what's the mandible?
This is mandible, so the mandible will shadow. Yeah, so if you go further back towards the ear. I mean, a machine with that, you can probably change the frequency, but what you would want to do is decrease your frequency because we want to get a bit more depth. The high frequency is very good image quality superficially, but if you want to see, so the sound gets worse as it travels through tissue and you get less quality at the back. So you have to change the frequency a little bit lower.
So what that white line, white part.
So this is all fat.
Oh.
Just soft tissue. Not fat, sorry.
Yeah, look.
Patients don't like it when you say that fat. I think that's too.
Okay, good, nice.
This is.
What's the parotid?
Is the parotid, so that's masseter, so move further back.
So what's the masseter again, please?
This is the masseter.
Right, okay.
Yeah.
Now this is.
And this is the parotid.
That's the parotid, yeah, so move further.
I'll check your button, don't worry.
The parotid, if you put, so angle of mandible and point towards the nose,
Yeah.
that's where you'd find it. So there's the angle of mandible, this is the parotid, this like,
Yeah.
the slice.
Okay, and this is the deep blue.
Yeah.
Going.
Tail.
Okay, sorry, this is
So we would, in imaging, we would call this the tail.
yeah.
And that's when it is useful to turn the probe in that longitudinal section, just because you can see a little bit more of it. And it drives the masseter there.
Nice.
The good thing about
Nice.
ultrasound is just, like a CT scan or an MRI scan, but you can find a little roadmap, you can work your way around.
Yes. That's
But you need
that's
to
lovely. Thank you so much.
Yes, you're welcome.
Have this.
Thank you very much. Thank you. You're very welcome.
Thank you for your.
You're welcome.